we had the suspensory ligament, which follow the ovarian arteries, vein. We had the ovarian ligament proper, which connected the ovary to the uterus. And then that continued forward from the fundus of the ovary. It's not shown in this diagram. Here would be the suspensory ligament. And here would be the ovarian ligament proper. And you notice we have these two structures right here that are lateral to the fundus, the oviduct and the ovarian ligament. So coming more anterior from this, we're going to have passing forward into the deep inguinal ring, the round ligament. And this is the only structure that supports or tilts the uterus anteriorly. Remember, it's really a continuation of the ovarian ligament. So if you look at this diagram, which you have in your lecture notes, this is looking down inside the pelvis. So notice how the oviduct in the ovarian ligament and the ovaries are lateral and posterior. And the round ligament is passing forward and into the deep ring. So from this view, you can also see the broad ligament, which is the mesentery of these structures. Remember the mesentery is what we call 2 layers of peritoneum. So where the peritoneum is draped over the uterus itself, it's referred to as a component of the uterine wall. What was our root word for uterus? What's the root word for uterus? This is the metrium, right? So as such, it's a layering of the uterine wall rather than a ligament. But where it drapes down, and I'll just kind of do that by giving this kind of impression, where it hangs off of the oviduct and the ovarian ligament, it is a mesentery or a mesometrium. Now, mesometrium is typically reserved for that part that is specifically lateral to the uterus. So right here. So broad ligament is used for all 3 areas. Mesometrium specifically this region that's lateral to the uterus. Mesosalpinx, or what is formed by the 2 layers hanging down from the oviduct. And it's hard to tell, but this is at right angles. And that is the mesoovarium. We have a pretty good plasticized uterus here. And I'm going to pass it around. Let's see if we've got, take these off. And I'll write a key to it on the board as far as these colored pens are concerned. homework, however. And the ovarian ligament isn't marked, but I think you can, the ovary is right here. I think you can kind of find it. Let me pass this around. And sometime during lecture today in lab, take the opportunity to take a look at this. So this is the cadaver's uterus. The uterus has been split open at the top. That's not natural. So you can look down inside. That's about the size of a uterus that is not carrying a fetus. Okay? It would shrink back to that appearance. So the last one up there, not the last one, but the yellow where it says uterosacral ligament, is one that's not visualized here. So if we move ahead again, to this image, you can see that last ligament. So this is very similar to what you're seeing in that plasticized model that's going around. The round ligament, see these three structures right here that I drew on the board? The most anterior is the round ligament, the middle is the oviduct, and the most posterior is the ovarian ligament proper. Right? And then down here near the cervix, we have the most posterior of all, which is the uterosacral. And it's the thickening of this peritoneum coming back, passing lateral to the rectum on each side, and attaching to the sacrum. So we talked about the uterus being antiflexed, then forward. So the round ligament keeps the top of it pulled forward. The uterosacral keeps the lower portion pulled back. Sort of keeps it tilted in that position. Right? So those are the ligaments that you're responsible for. Now let's come back again. We've started to talk about the layers. So I have perimetrium up here. And then we remember our muscle wall is smooth muscle. And our prefix for muscle is either myo or sarco. And so this is identified as the myometrium. And then we have an inner lining of epithelium, which is simple columnar epithelia. Under every epithelia, we have loose, irregular connective tissue. And then, kind of like the dermis of skin, it changes to dense irregular. So this is a rather thick layer of a simple columnar epithelium thrown into glands, and I'll draw a diagram of that larger in a bit, attached by loose irregular and dense irregular connective tissue. And this is the endometrium. So this is what's going to be affected by the hormones, estrogen and progesterone, and at varying levels in the uterine cycle. So this, a microscope slide of these layers, the same image that you have in your lecture kit, shows all but the perimetrium. So down here we have some of the smooth muscle of the myometrium. And then starting at this point, we have dense, regular connective tissue all the way to the surface. So this would be the endometrium under influence of estrogen and progesterone, probably close to mid-cycle or a week after, so like the third week of the cycle. Not close to, but not quite to mid-season. So it's about as thick as it's going to get. Two things are affected under hormones in the growth of this endometrium. when we talk about the hormonal changes, I'll go over those again, but estrogen affects the growth of the dense regular connective tissue in the glands. So these open structures right here that look coiled are uterine glands. As we move through the menstrual cycle, they become filled with glycogen, which, if the egg is fertilized, functions as an early source of nutrient for the fetal tissue until a good blood supply becomes established. A little more difficult to see in here are the spiral arteries. And under influence of progesterone, the spiral arteries grow very rapidly and become even more hairpin in their turn. And you can see the arterial pattern here. So the uterine artery, which is a branch from the pelvis, passes through the myometrium from these radial arteries and then enters the endometrium, which is the lavender area here, as these spiral arteries. So with increased growth in the tissue and the possibility of implantation, even more blood supply is needed, and they become very longer but more tortuous as they become compacted. Okay. We'll talk about that as a source of contraception, because blocking at the end of the uterine cycle, the reason that menses occurs is progesterone levels dropped. And progesterone levels maintain increase the growth of these spiral arteries. Without progesterone, these spiral arteries start to die and constrict, and this tissue loses its vascular supply and separates and sloughs off. So there is a medical abortion pill called RU-486. About 10, 15 years ago, before it was okayed by the FDA, it was often referred to as the French abortion pill. And it binds to progesterone receptors as antagonists on the blood vessel walls, on the smooth muscle, and prevents progesterone from attaching, so the same event occurs. You have constriction of the blood vessels, separation of the tissue, and if there's an implanted embryo, that separates as well. So it's sometimes referred to as a chemical abortion rather than the scraping of the tissues. So let's go back and look at this tissue here. It's divided into two layers. So this lower region that is the most dense is also the base, where the base of the glands are located. Let's see where I can place this. You guys want to take a picture of this? Up here? No, I erased it. At least part of it.
Dashes part of the endometrium?
The green dashes is just showing the myometrium, the broad ligament. Which reminds me, while you're taking that picture, I brought this older motto out. So this is showing the double layer of peritoneum that forms the broad ligament here. But the reason I brought this out is, remember I said we had an older model that showed the remnant of the mesonephric duct? And that's what you see right here. Within the mesometrium, it would, this was the testis, those would form the efferent ducts. So it's a remnant of the mesonephric tubules and a little bit of the mesonephric duct right there. Non-functional, because there's no connection. This would be there's no connection to the paramesonephric duct structures. So it's just kind of left behind. And sometimes it can be seen and sometimes not, but that's about all we have of the mesonephric structures. Okay. So when we have our base myometrium, and our blood vessels coming up through here, and we start out right after recovery from menses. Right after menses, the surface is raw and nude, and there is no epithelium. But the uterine glands, which are simple columnar, give rise to and replace the epithelium that was lost during menses. Okay. So this denser region right here, where we have the base of the uterine glands, is identified as the stratum basalis, the basal layer, similar to what we talked about with the epithelium of the skin. So stratum basalis. And this would be, say, menses last through the first 5 days of the period. So say day 6 and 7, this has grown out and has now replaced the epithelium. Same as if you were to have a burn and you've a second-degree burn, the epithelium of sweat glands can grow up and replace the epithelium on your skin. Now, under influence of estrogen, the connective tissue increases in growth, and this grows longer. This is a much denser connective tissue. This is kind of still dense, but not as dense. And so this layer is now referred to as the stratum functionalis. So most of the stratum functionalis is what is left, what is lost during menses. So menses would occur down to about this level right here. And then this will stay the same, and as this grows thicker, that's the stratum functionalis, growing thicker as a result of estrogen. So there's a thickness of the connective tissue. There's an increase in the growth of the glands. So this would be the uterine gland. And then after ovulation, when progesterone hormones rise, there is a very rapid, this is going to be there as well, but there's a very rapid growth of the spiral arteries. So both estrogen and progesterone are influential after ovulation. Prior to ovulation, it's primarily estrogen, just in the growth of the thickness. And this again is all in providing nourishment for implantation. So this view here shows just very little endometrial tissue without any epithelium. So this is during or immediately after menses. All right, then we recover that epithelium as the glands, leaves of glands cut in cross-section. So down here's the stratum basalis, and here's the stratum functionalis. You can see it's less dense. The uterine glands are growing. That's the proliferative phase or pre-ovulatory phase. And then after ovulation, we have this rapid growth of both the glands and the blood vessels. What you're seeing here are the glands. And that's called the secretory phase or post-ovulatory phase. And that's where we see a maximum rapid growth. That's part of the uterine changes. So when we look at the physiological aspect of reproduction, we'll start that today, we probably won't finish it. We have changes in the uterus. Well, first of all, we have hormonal changes. And they result in changes in the uterus and changes in the follicular cells around the egg. So we have a uterine cycle and we have an ovarian cycle or follicular cycle. And they're tied very closely together because it's the changes in the follicles that cause the changes in the hormones that reflect back on them. Now, when the endometrium is sloughed off during menses, it typically goes down the cervical canal and the vagina, but it doesn't have to. Remember, the oviducts are part of the uterine cavity as well. And so endometrial tissue can pass out the oviduct, and because the oviduct is not a continuous tube with the ovary, some of this endometrial tissue can move into the peritoneal cavity. And it can land anywhere. And if it lands on a site with good blood supply, it will be viable. I remember hearing about a case of a woman who since early puberty, maybe before she was 20 anyway, started suffering extreme pains associated with her period, but they were down in her leg. And it wasn't until she was in her late 30s or early 40s before they finally figured out that that was endometrial tissue that had passed down the femoral triangle where the femoral artery and vein and nerve enter into the thigh and pull down with it a little triangular capsule of peritoneum. And she had endometrial tissue all the way down there. So hormones, remember, are blood distributed. So as our estrogen levels and progesterone levels rose and fall, it affected that tissue as well, which would grow and shrink and cause the inflammation and the pain that she was experiencing. But it took about 20 years before anybody found out, even though, I mean, it was associated with her period, they knew that, but they just didn't realize that endometrial tissue had distributed that far out of the peritoneal associated cavity. All right, so let's move on from the uterus now to the vagina. We were driving through Sac State yesterday. I apologize. I don't know if you guys came for office hours. I called the office and asked them to put a note. I got a really bad cold over the weekend, so I went to bed at 5 o'clock last night. Like, it's worse than the pneumonia I had as far as how I feel. So I'm drugged, so if my words don't make any sense, I'll blame it on the drugs. But we were driving through Sac State, and my daughter, they have a sign up. They're doing the vagina monologues again. And the big word vagina was huge on this sign, and my daughter looks at that and goes, "Mom, why do they have that word up on the side for?" And I said, "It's kind of a play." Yeah. She didn't ask to go, she said.
Not only is it huge there, it's huge by the Guy West Bridge as well.
Pardon?
It's huge on the entrance to the Guy West Bridge.
Oh, is it really?
Like up to its vagina, like, okay.
So we've been talking about, coming back to what we've looked at here. Here's the oviduct again, and barely visible the round ligament. Here is the perimetrium. And notice it doesn't come all the way down to the cervix. It folds back up to go over the rectum, and folds back up here to go over the top of the bladder. All right? If there is a growing embryo and fetus in the uterus, and this actually grows up when a fundus can meet the diaphragm, then more and more of the uterus would actually be surrounded by peritoneum. But without a pregnancy, the cervix is not considered to have any association with that. The cervix is this region right here. So this would be the cervical canal. We talked about the internal os and external os. And so the cervix actually bulges down into the vagina. By doing so, it creates a moat-like ring of space that is vaginal space. So that's what we see here. We see this in sagittal section. So in a sagittal section, these two areas of the moat, think of it as a box rather than a ring, all right? So there is an anterior and a posterior aspect to it in that view. If we look at, I kind of draw this in a sagittal view over here. Then we would have the vagina. And this would be the anterior fornix. And posterior fornix. Actually, the posterior fornix is a bit deeper. But in this view, it's a frontal view, and so we see visible two lateral fornices. Fornix is singular. Fornices is plural. So it's a vaginal space created because you can see it on that model. It's the plasticized tissue that's going around. So if you look up inside the opening, so there's a bladder structure. This would be the bladder that's been cut open, and this would be the rectum. It's plasticized poop, so don't worry about it. It's sterile. And this is the vagina right here that's been split. If you look up inside, you can see the cervical opening. All right, so there's three. Bladder's been cut open, rectum is there, and here's the vagina. where this pen is, and the pen is on the cervix. The one form of birth control is a diaphragm, right, with it's kind of a dome-shaped structure that has a thickened rim, and that rim is designed to fit up and surround the cervix, fit up into the fornix. So it needs to be refitted if a woman has children, because the cervix changes in size and the vagina changes in size, and so that fitting needs to take place. All right, after that, the vagina is basically a smooth muscle tube. It has a lining. If I can erase this diagram here? It has a lining that is the same type of epithelium as we find in the anal canal and the esophagus. So the surface is non-cornified or non-keratinized stratified squamous epithelium. In some animals, this changes from keratinized to non-keratinized, depending on whether they're in heat or not. Right? So in rats and other rodents, that cornification portion changes. So this is a non-cornified, which if you didn't have elastomeric means the same as non-keratinized, stratified squamous. It's thrown in folds, which are known as rugae. We'll have rugae in the bladder and rugae in the stomach. And then its wall structure is smooth muscle. It doesn't have any serous membrane around it because it's down the pelvis. So it's not associated with the peritoneum. The connective tissue just blends in and attaches it to surrounding tissue. It has no glands, right? It can become moist during sexual arousal. But what happens is fluid from the surrounding connective tissue just seeps through the epithelial cells into the surface of the vagina. So there aren't any specific glands. Until we get to the vulvourethral gland, right? And that lubricates more the external genitalia, the labia, than it does the vagina. Now, prior to intercourse, here you can see another view of it. Prior to intercourse, the vagina will have a membrane that typically is partially covering it. Occasionally it can completely cover it, and then it needs to be inside to allow menses to drain out, obviously. This is a series of diagrams from Netters that shows variations in the hymen itself. So this is after childbirth, after intercourse, a little bit larger after childbirth. So you can see a little bit of some of the remnants. This is the opening of the urethra, glans clitoris, and the labia minora. Now, the old saying is if a woman's hymen has been torn, then she's not a virgin anymore. With modern practices, with horse riding and the use of tampons instead of pads, digital intercourse and so on, it's not uncommon for a woman's first intercourse to not be painful and to not bleed. So you can't make that assumption unless you consider digital intercourse to be sexual intercourse, but it kind of depends on your definition of that. But again, the use of tampons and so on can gradually enlarge the hymen itself without tearing it. So now let's look at the external genitalia, and I'm going to completely erase the board. Anything else up there that you guys want? Okay, similar position that we had the male on, and we were looking at the erectile tissue on Thursday. So here we have a triangle appearance. The hair pattern to begin with is the reverse. It's called the escutcheon. Either a C or a K. You should see with a K. So in the male, it's shaped like this, with the broad base of the hair pattern at the scrotum. And this would be at the base of the shaft of the penis, but the rectangular line extending up to the umbilicus. I don't think I need to show you that this is male with the word penis up there, but just in case. And then with the female, the broad base is the hair that covers the mound of fat over the pubic bone, or the mons pubis. And this would be at the anal canal. Typically here, so you have this kind of a pattern like this. And the hair would be on the labia majora. So here we see, without the hair follicles, the larger, thicker lips have adipose tissue. These aren't freckles, these are hair follicles. Labia majora, okay? And then within them, we have the thinner lips that do not have hair follicles, and these are the labia minora. Labia minora fuse at the top to form a clitoral hood or prepuce of the clitoris. It's the same as the male foreskin or prepuce. Visible under that would be the glans clitoris. And we'll talk about female rectal tissue in just a moment. And then also you would have the opening for the urethra. And the vaginal opening. So back here are the ducts for the pair of glands, the bulbourethral glands, which are homologous or equivalent to the bulbourethral or Cowper's glands in the male. So we'll look at that again as a sagittal view. And so they're going to lubricate the external vestibule, if you will. The vestibule is this space here between the labia minora. And the bulbourethral glands will lubricate that region, and maybe an inch or so of the inferior vagina. The rest will be lubricated by the seepage of fluid into the vagina. Some women are born with really long labia minora, or one side longer than the other. Childbirth can also stretch it out and makes it change its color from a pink to a darker purple. And so becoming more common is a surgery known as labiaplasty, in which the labia can be reshaped, either for cosmetic purposes, or if it's a really long labia, it can interfere with intercourse because it gets kind of dragged into the vagina, and so they can be shortened and reshaped for that purpose. Now, if we look at these same structures from a sagittal view, okay, here's the mons pubis, here's the labia majora, the labia minora, and here, just at the base of the opening of the vagina, are the bulbourethral glands. They have three names. So bulbourethral glands are also known as, I'll write them over here where they're a little bit easier. Greater vestibular. Or bartholin. It's easier just to refer them as bulbourethral, then you can use the same term for both male or female. Okay? But any of those terms are acceptable for a lab exam or a lab quiz. Yes?
So what did you say about the vestibule?
The vestibule is the space between the labia minora. Let me go forward to this view. Maybe easier on this slide without all the other terms. So here's the labia minora. So this region right here is the vestibule. Now, couple more things. Here is the external urethral sphincter in the female. That same fills in the triangle of the pubic angle. So you can see, just like in the male, the bulbourethral glands are on its inferior surface. And then we have, along the urethra, a couple of pairs of glands that are known as the paraurethral glands. An older name for them is skenes, S-K-E-N-E-S. And these are homologous to the prostate gland. All right, so this was accepted in about 2001, that embryologically these had the same embryonic origin as the prostate gland. You don't hear of women getting paraurethral cancers very often because testosterone levels are lower in females. But if a woman ejaculates or has a secretion of fluid during orgasm for a long time, that was thought to just be urine. And the woman would swear, no, it's not. And you can test it with pH paper, and it didn't have the acidity of urine. And so finally, a little over 10 years ago, this is accepted to be the equivalent structure. In guys, they talk about the G-spot, manipulation, massage of the prostate through the rectum, which is the only access you're going to have to it. It can increase sexual sensations. And in the female, there's a book's been written about the female G-spot. And so that's, again, related to the female, quote-unquote, prostate gland. Yes?
Are there two bulbourethral glands in
Yeah,
the male?
there's one on each side of the urethra. Yeah. Okay, let's look at the erectile tissue, and then I want to go through the equivalent structures now that we've talked about both male and female. All right, and then we'll take a break and do lab on female reproductive structures in male. But then I want to come back before we leave and talk about the hormones and move into reproductive phys. Okay, but I want to have a lab on these anatomical structures first. So this is the appearance, may I raise the board? This is the appearance of the erectile tissue of the female. We have the same structures, not as large, all right? And some portions seem to have disappeared. But overall, essentially the same structures, the erectile tissues, and the woman would have erection, modified emission, modified ejaculation. So let's diagram the female pelvis on the board. We have a wider pelvic angle since this is a female. And I'm going to be erasing part of this as I lay the erectile tissue over it. So remember in the male we had the crus of the penis on each side attached to the ischial rami and inferior pubic rami. In the female it's primarily the inferior pubic rami because they're much smaller. So rather than all of this being the crus, we're going to see a smaller body. And so this would be the crus of the clitoris rather than the crus of the penis. Plural would be cura. And then the corpora cavernosa would form the body of the clitoris that you see here. Now remember, in the male, we have these structures, just a little bit larger. We had the bulb of the penis, and that formed the single corpus spongiosum. Now we've got the vaginal opening in the perineal area, and so the bulb ends up being split. We have two bodies, two structures, right here and right here. Let's see if that's in the middle. Now, we do have, remember what formed the gland penis? It was a mushroom-like cap structure from the corpus spongiosum that covered the tips of the corpora cavernosa. So we see the same thing for the female. What we don't have, typically it's hard to find in dissections, is the corpus spongiosum connecting the bulb to the glands. So some diagrams show this kind of a few strands in there, but absent from the ventral surface of the clitoris. So structurally, embryologically, it would have had to exist to create the glans clitoris, but in the adult, it's really difficult to find that structure. So we would have the bulb of the vestibule, glans clitoris. Question mark on the corpus spongiosum.
That's not for the labia, right? The bulb?
No, the bulb is just deep to the labia. But that's not what I drew. So here's the greater vestibular gland posterior to the bulb, but I'm not drawing it in there because it's not erect tissue. So this is a diagram for the female from Netter's, and this is most similar. Our model that I pulled out last time to show you the external urethral sphincter is of a female pelvis. So this structure that you see here is showing the bulb of the vestibule, whereas on this side the bulb is covered by the bulbospongiosus muscle. And then the ischial-cavernosus muscle is covering up the crus. You can't see the crus. But that's showing the labia minora right there. And the bulb of the vestibule is kind of at the base of the labia majora and under the labia minora. Okay. So here would be the same structure here. Here's the labia minora. You would have the bulb of the vestibule covered up by bulbospongiosus muscle, and here's ischial-cavernosus muscle that would be covering the crus of the clitoris. Okay. So here's the crus, giving rise to corpus cavernosum, forming the body, and glans clitoris at the end. Here's the bulb, and it's like, well, what happens to it underneath? So some texts say it's still there, and some say it's disappeared, and so it's kind of like with a question mark. Okay. So if we go back to a sagittal view, what you're seeing here is a bit of the crus, mostly the body, and then this would be the glans clitoris. So where it calls it clitoris, it's like calling the tip of the penis and not going any further than that. Yeah, it's part of the penis. But this specifically, at that portion there is the glans clitoris. Okay. Now, we didn't talk about circumcision in the male, but circumcision in the male, as most of you know, is removal of the foreskin, okay, or the prepuce. It's typically done in an infant. When I was working in the hospital, they would do them when they were, just before they were discharged at 3 days, so they do it like on the second day. Basically, the babies that were going to, the obstetricians did it. Now it's the pediatricians, but they would bring a baby in, and we had a big board like this, depression the shape of the baby, pull their arms out, strap them down with Velcro straps. It was called a circuit board. And they would lie there and cry, almost themselves asleep by the time the doctor showed up. And the most common instrument was a metal ring called a Gomco clamp that they'd slip down over the penis, pull the foreskin down, and then a bell-shaped structure would come down, screwed tight on top of that, and a quick swipe of the knife, and you get this donut ring of foreskin. And they'd unscrew the bell-like top, and there'd be a little bit of bleeding, and they'd sprinkle a powder that coagulated and stopped the bleeding, and wrap it with a piece of gauze that had the same powder and Vaseline on it. Change that every time the baby's diaper was changed, and by the time they went home, it had started to heal. So when my first son was born, I hadn't worked in the nursery for probably 5 or 8 years. And they asked us in the hospital if we wanted our child circumcised, and my husband circumcised, and I said yes. We said yes. So the pediatrician said, we'll bring him to my offices in about a week, which is typical. I think the 8th day is when Jewish circumcisions are done. Our pediatrician was changed Jewish, so I don't know if that had anything to do with it or if that was just his schedule. It's actually when vitamin K levels in the infant have risen, so it takes them about a week for internal flora of the large intestine to grow and produce vitamin K for clotting factors. It's standard to give babies vitamin K within a few hours after they're born, so that's usually not a problem. So I took him in, and the doctor did it in his office. He was on a table. I sat here, my husband faced me, and the doctor injected a local anesthetic at the base of the penis, which I'd never seen done before. And that really, I mean, Chris just screamed. And I said, I've never seen this before. He goes, well, studies have shown that babies do feel pain when they're circumcised, and this is a local, which any of you that have had locals, they don't always feel very good either. I had them all over my face for some procedures, and proceeded to do the circumcision. I've been through like over several hundred, and I was fine. My own child, my husband's knees were touching mine. I was holding on to one of his big toes, and I didn't look at my husband because I knew if I looked at my husband, I was going to burst into tears. When it came time for our second son, 5 years later, I just gave him to the nurse and said, bring him back to me when he's done. I don't want to be there. Neither of them remember whether I was there or not. Our babysitter at the time was Chinese, which she still is, but she's just no longer a babysitter. And she had her son circumcised when he was 5.
Oh.
That was a little bit more traumatic. And some men who aren't circumcised will decide to be circumcised when they're older, either because they convert to the Jewish faith or for other reasons. Typically, if it's not cultural, San Francisco actually tried to outlaw circumcision as child abuse. That kind of got shot down. But typically, if it's not cultural, it's for ease of keeping the penis clean. Children can be taught. I babysat for a friend of mine whose son wasn't circumcised, and we just had to make sure he was 3 so at the time to pull back the prepuce and clean around it. So an article came out about 16 years or so ago saying that it wasn't necessary for cleanliness purposes for men to be circumcised. There's some discussion that they have less sensation with circumcision. I don't know, if you were circumcised as a baby, you probably wouldn't know the difference. As far as whether it felt better or not during intercourse, you'd have to rely on the adults that were circumcised. And about 3 months later, the American Journal of Obstetrics and Gynecology came out and said, well, it may not make any difference for men, but women are less likely, or like 3 times more likely to get sexually transmitted diseases and cancer of the cervix, mostly the cancer of the cervix, if they have intercourse with men who are not circumcised. But again, that's a cleanliness issue, all right? So it kind of boils down to, unfortunately, what the parents want, not what the kid wants, because he doesn't have any say about it. But again, it's kind of like breastfeeding. Numbers of kids who are circumcised rise and fall with trends, kind of depending on their parents. So that is circumcision in the male. Women can have their prepuce trimmed, but typically when we talk about female circumcision, it's much more drastic, and it is removal of the erectile tissue. So it is removal of all of this. All right, so a woman who has been female circumcision is unable to have an orgasm. She can't reach a climax because she doesn't have that erectile tissue. All of these tissues would enlarge. Females undergo erection, okay? They go from a small P to a big P size, but it's still an increase in blood flow. About 10 years ago, when I was giving this lecture, I had a student who was from Nigeria. Had come to the States and married a guy who was American, but I think also was from Nigeria. And after I gave the lecture the next day of class, 2 days later, she came to me and she said, I wanted to thank you for this information. She said, I called my ex-husband and apologized. And I said, you apologize? I couldn't think of anything I had said that would make her have to apologize. And she said, well, when I came to the States, I had a female circumcision. She said, my OBGYN actually accused me of having done it to myself. And in some cases, it's not just a female circumcision, but they actually suture the labia together in between the periods, all right, to control sexual activity. She said, I had 3 kids, and then we got divorced, and in the divorce papers, one of the reasons he gave for divorce was that I couldn't have an orgasm. And I got really upset with him and told him that he was wrong. Obviously, I could because I had 3 kids. And she said I didn't understand the rectal tissue part of it and the sensation components because she didn't have that tissue. So obviously, she wouldn't know unless she could remember from childhood if she'd masturbated or anything what those feelings were like. And she actually called up her husband and apologized for her rebuttal against his statements in the divorce papers. But more importantly, she called her mom back in the home country, and at least verbally over the phone got her to say that she wouldn't have her younger sister circumcised. So it's done in the States, mostly by individuals who have immigrated from other countries or have accepted their culture, but more commonly done. I hadn't even heard of this until I was in college, and there was a large movement started to kind of try to eradicate female circumcision. That's what it is, and why it's so drastically different. It's not going to affect, obviously, a woman's reproductive capability, okay, because the ovaries and the uterus and the vagina are all there intact, but not even her desire, because the ovaries are still secreting estrogen and testosterone, but her ability to feel any sexual sensations. All right, so let's stop there. The nerve pathways, I got most of that done Friday afternoon, and then I went to bed and quit working. So I'm almost done. I just have to do the last 2 nerve pathways. The structures are there. Remember I said I would give you, maybe I did, but anyway, the second class, I didn't do the diagrams that I did on the board for you in the 104 room. And so I'm drawing that on PowerPoint for both of you guys. We took pictures of it. I'm drawing it out, so I'll upload that to D2L. I've got a couple more slides to finish. Let's take a break, and we're going to be doing the clay modeling. So hopefully you remember to bring your clay. If you didn't, there should be some available at the bookstore. Somebody might be able to share. So we're going to model both the male and the female. And then we'll have lab time to look at both male and female structures. You have another quiz on Thursday, I believe. And that's male, along with male histology. So on Thursday's quiz, it will be all male organs, and slides of, say, is this the vas deferens or the epididymis? Slides of the testes, where you would have to identify spermatogonia or primary spermatocytes. So it's not only histology, but histology will be included. Okay. So both male and female models I will pull out. But first of all, we'll do the modeling. So why don't we'll start lab at 10 up. Okay. So 15-minute break.
Bring all the fruits or whatever.
For the female, obviously a broader angle. So that's the structure that you're going to attach the crus. We do the male first. The crus, crura of the penis and the vulva. So you want to choose a color that will be both your crura and corpus bodies, and make 2 elongated columns of clay, depending on the size of penis you're going to give this guy.
What does that mean? The size of penis you're going to, well, if you found me too big, I only have this much clay.
No, it's not as complicated as it was in the brain, so that's our diagram right there. Okay, so if this is one crus and corpus cavernosa, the way I'm going to show it to you on the pelvis I happen to have in the female, but we'll make that into a male or a female. And so the base, the crus, is going to rest on your countertop. Okay, my hand's the countertop like this. Okay, so this is going to be attached to the base of the paper like that, and then make another one that pairs it like that. So these 2 angles here represent the ray line of the ischium and pubis. And so what's attached to the paper will be the crus, And what's coming up off the paper towards you will be the corpus cavernosum. Okay? So I'll make another one, like that. Will the ladies share their paper with you?
Oh, no, I'm fine.
Okay. So kind of make sure they're the same size. All right, so now I have two. So on your paper, it should look like that.
Just one side.
Okay? Does that make sense? If I put it on the pelvis, and again, remember this is a female pelvis, not a male. So the angle should be a little bit sharper. Then the crus is going to be attached via connective tissue fascia to the ischial and inferior cubic rami. And at the cubic symphysis itself, the two corpora are now free of the bone. And so we have this structure. Okay? So what you have attached to the paper is what I have attached to the bone, and that's the single crus of the penis. The two together would be the crura of the penis, where it comes free of the bone, and the upright portion of your structure where it becomes no longer attached to the paper would be the two bodies or corpora cavernosa.
Let's keep looking at that.
So these should probably be the same color, just to remind you that they're in the same section.
What the hell was that? Oh, that was sorry.
Okay, so the next structure now is to make the bulb of the penis, and that is going to develop into the corpus spongiosum. So I'm going to save my reddish colored clay for the muscle covering. If anybody wants, I've got plenty of clay up here if you don't have enough, if you've got to bring some. Scratch some from here. So we need a ball, a round structure, right, and a elongated structure. And the one at the end that needs to be flattened out, but I need the bulb, I need to make the bulb part first. Now you guys have a tabletop to support your bulb. I've got empty space, I'm going to have to kind of hold it. Remember, the bulb is where the urethra penetrates into the penile structure to form the first portion of the female urethra. So it passes through the prostate and then the external urethra sphincter and then into the bulb. So, looking for us, you can take one of these sticks and kind of make a opening there for the urethra. So this is going to, you're going to place this here as the bulb, and then under the ventral view of the penis is going to form the corpus spongiosum. Okay? And then if you have enough clay, you could expand the tip into the glans penis. I'm going to have to add some more to make that little mushroom-like cap.
Any more? It's kind of short. It's not happy. You guys are bad. I'm trying to. I'm trying to.
All right, then the bulb goes here. And on the ventral aspect, like that. And then I need my little cap.
Oh.
So now I have the bulb of the penis, corpus spongiosum, and glans penis covering the tip of the corpora cavernosa. Now, every once in a while for convocation, the day before classes start, they ask for volunteers to come and give their favorite lecture. One of these days, I'm going to have a room full of faculty doing it. Yeah, I learned how to take sprained ankles. They can learn how to make a record, right? Now this is actually can do above there to cover it.
Okay,
I don't
so
know. Yeah, and again, that's
There it is.
corpus spongiosum.
Okay, so that's their erectile tissue. Now, remember our skeletal muscle tissue covered this. So we have two pairs of muscles. Down there like that. So I'm just going to put it on one side so we can still see the erectile tissue. So covering the crus, we have the ischiocavernosus muscle. And covering the bulb, we have a pair of bulbospongiosus muscles. My female pelvis keeps rejecting the male penis here. So the ischiocavernosus muscle is going to cover, that way it can compress when it ejaculates, the crus. All right. And then it takes two muscles fused here at this raphe to cover the bulb and lower part of the corpus spongiosum. So the ischiocavernosus doesn't go on to the corpora cavernosa, but the bulbospongiosus muscles will cover the bulb as well as part of the corpus spongiosum. So
Cover the bulb and
kind of in that fashion, and then part way up the shaft.
how far up the shaft to
About
a bone?
20%, 25%, so kind of,
The bone doesn't come into play at this point. The issue.
right.
Okay, just this comes up to a point. To a.
So there we go. So I don't have an ischiocavernosus muscle on this side, a little lopsided penis there. But I have both bulbospongiosus muscles and an ischiocavernosus muscle on that side. It's still the bulbospongiosus muscle, they don't fuse in the midline.
Oh, I gotta get those.
So we'll do the female next.
You kinda got it.
Again, that's really difficult for me because I don't have a platform for that. So covering the crus, ischiocavernosus muscle, covering the bulb and part of the corpus spongiosum, the bulbospongiosus muscle. Two of those.
I think right. And then you have they're not attached.
So the red would be the two bulbospongiosus muscles and one of the
The two in the
ischiocavernosus.
middle are. Oh, but you mean like this one and this one? No, not.
Okay,
And that's, yeah, then that's what we see to the far right with the white stuff missing. Is the issue cavernosus muscle. The one in the middle is the seam. The bulbous,
I like your
bulbous spongiosum muscle.
Issue cavernosus. And that is the muscle, so it's
Just chilling.
It's chilling.
And I'm just showing one issue cavernosus.
No, think about it, isn't
What?
So these are here, mobile, scoliosis, and then under this part,
So this is additional spongiosис, bulbous.
Okay, I gotta ask her which one.
Issue
She only made one big
cavernosus.
one too. Is there only one big vocal?
There's actually two. Together.
Is that what's over the, is that the anus?
Above the anus, yeah.
Oh, so we're
So,
looking at.
yeah, there would, I
Part
just
that's
needed one
together.
covered so you could
Have
still
a white
see the
line down
rectum
the
tissue, but there would be
We're looking
two
at that one.
ischiocavernous muscles, and here we have
And the bones underneath it.
two
I thought, that's
bulbous.
what, I thought it was that, okay, I'm
That's
not.
okay, I keep it all
There's two ischiocavernous muscles. I just showed one.
Yeah.
And then we have two bulbal spongiosum muscles that's used in the middle.
Okay.
That's what I showed on that.
That bulb.
You only made one penis?
Okay, so now we're gonna do the same thing for the female, but much smaller, all right?
Okay, so this is the male. Okay, this is our female. We'll do our female thing.
So I'll leave this up here, I'll get some paper to put it on. You guys can take a look at that. And now the erectile tissue for the female, same thing, let's form a crus and corpus cavernosa.
Let's do great. Just because they're,
But much smaller crus.
oh wow, yeah, really small. We can use that, just the cruise for both sides. Because we only have that little bit. Let's go see if we can. No, but looking at the pictures seriously, it's just so thin.
Oh, small.
Oh, that would be cool. Because the pictures are nice. Like I kind of understand it, but just be able to see it. So that's our cruise. See our US, right?
Okay, so here's the crus and corpus cavernosa of the female.
Okay, the corpus cavernosa of the female doesn't,
Again, doesn't touch to the bone. So the crus is what's attached to the inferior pubic rami, and then the corpus cavernosa are this structure here that is not attached.
kind of like a mini penis.
So
I
say,
mean,
yeah, exactly.
That's girl, that's what I
Exactly.
thought. I was like, why does that look like a penis?
it does, but it is, but it's, okay, so,
Yeah, it just says it's just what we just did, just everything's smaller.
okay.
I was like, that's interesting.
So, crus, attached to the bone,
These are all
corpus cavernosa,
up here.
sending out to the like making a miniature little piece, or the crus and the corpus is third.
It shows down to here what they turn into. You can't really see if you look down the half
So
here.
baby girl is born with
That's super red and green.
They
These
want
two
antigens
the
with
one
how
that's
they
red
are.
up here and green up here came together to make one big, so it makes like a striped color. And down here to show you exactly what it is. That, okay. So I think it's a different drop box. Yeah, that would make sense.
All right, now when you make the bulb, you have to split it, okay? The bulb is much longer and flatter, so it's not round. So it's two elongated oval structures, kind of flattened like this in this fashion. And again, I don't have a flat surface on my female to attach it to. I don't have my external urethral sphincter there. But if we were to do it on the diagram up here, it would be like this. My diagram's a little large for it. Okay.
Oh, those are.
But like that. So the vaginal opening would be in here, okay? And the bulb is separated because it has to go around the vagina rather than one single structure. All right? The vestibule is the space between the two labia, so the bulb would be within the vestibule. So if I take this off of my bone tissue here, that's what you're doing now. Okay? Now my bulb I actually did in yellow, so let me continue with it. All right.
Yeah, see, this is the male bulb, this is the female bulb. This is the, oh,
Well, let me do that in different colors because they really are separate structures.
right? They know? Because they're, so, okay, that's the cruise, then this up here is the, this is the corpora
So that would be the bulb. And what we have difficulty finding would be the corpus spongiosum. So you can see how this one kind of tapers up there. So we can put some little strands. Because it definitely was there at some time because we still have the glans clitoris, which again is that mushroom-like cap. There. So I'll leave that up on the board as long as it's sticky. And you guys can, oh, come on.
That's good.
Okay?
No, it's back, you leave it up on the board.
So the
So the bulb of the vestibule is what it's called.
bulb of the vestibule is this guy here. And they, do they actually touch
Up near the top, they may.
in the top?
There. You guys want to take pictures, you may.
Chris?
And then we would have the muscles by the same name that cover this tissue. We would have the bulbospongiosus muscle would not be joined together like it is in the male. But we would still, so here's the bulbospongiosus covering the bulb of the vestibule, tissue of cavernosus covering the crus.
And the things that weren't there, that were still, is the corpus spongiosum,
Right.
the little,
So the
kind of
little
hanging
bit
down,
of orange I have coming up here,
like it's holding on to, kind of.
the corpus spongiosum,
This is the corpus spongiosum.
and the glands. Crucible critters, all other vestiges. It may not be complete, but it would have at some time been connected that way.
Not there, but it is there.
Very good, starts to stay my boy, and I'm like, that's not there.
I think we did okay.
Okay, so, for the rest, I'd like to come back to lecture in about an hour. So, for the rest of the time, you can look at the models. And we have the male slides over here, and I'll bring up, I won't bring up the female slides yet, because we haven't quite covered all of that material yet.
Is your guys' penis better than Joe's?
Of course.
Let me go get our older male. Yes?
The muscles on the female, would it go right here?
Right, well, not quite, they would cover this
Okay.
down to about here, and then cover this on each side.
Okay.
And similar to what you see on the screen or
So you just fix it back.
that model. So here would be the vulva vestibule, vulva spongiosum muscle, facial.
Are you just go all the way up?
But the
What?
cruce to the stop right about.
Are you trying the female?
Yeah.
Yeah, it used to be, see how it is on the board, the corpus spongiosum? It possibly could go all the way
Okay,
up,
so here's the
because it
ball.
was there once.
No, I'm talking about the muscle.
Side is covered by the
Oh,
vulva
I'm sorry.
spongiosum muscle. The cruce only gets to here, but the ischial cavernosus muscle is about the same size
I
as
give
the
you life
male.
advice.
No. Maybe that's the reason why I can't see. So are we through with the play? I think so. Are we gonna have? Ruins my life. I think this is the only diagram we do this semester. I don't know.
We use clay once more.
Last semester we only used it once.
This isn't last semester.
I know that.
Sort down this, so you have to find.
Awesome.
Small instructors.
Nice.
I know, I feel bad about that, but I had to go to class. I honestly do feel bad about that.
That's what is so much.
I have that same outfit on my. I have that some things that I've noticed that shoes, like, they come like a lot of people, like,
Nice. Got it all.
tell them it's Tuesday in here. All the names.
That's what I'm doing, yeah.
Come off one way.
So is it real, or is it just a hoax that they're investigating
For what?
being raped? That
We have a tiny
The
little
Broncos took a large
vagina and a huge ass clitoris.
Richard Sherman came out and said
Let's see
that
yours.
after the first two plays, they figured out, they had
Hold on,
basically
go
just
find it.
used
There it
the
is.
filming doing his audibles of the line, and they figured him out, and that's why they were basically able to pick them apart.
See, and where's Joe so we can compare all three?
Let's compare and post it online.
The Broncos rolled over. Honestly, I don't think the Broncos played bad, as I think the Seahawks played phenomenal.
Now we can show everybody Joe's penis that he was talking about on Facebook.
This isn't drawing it though. Mine even has a seam.
D, GnRH. So remember the hypothalamus is going to synthesize, there's an extra chair over here. Yeah. It's going to synthesize gonad. Remember GnRH stands for gonadotropic releasing hormone. All right. And that's going to go into cat bed 1, travel through the portal veins, exit cat bed 2, and affect the pituitary cells to make LH and FSH. All right, may I erase the board there? You guys, you have pictures, I have that copied down. I have no idea what
I
happened
don't
to.
know how it got over here.
Okay, it was me, I'm sure what happened.
Can I take a picture real quick?
Yeah. So GnRH is going to bind to a receptor on the surface of the gonadotroph. And what type of G protein activation is that going to be? The phospholipase C, IP3, DIG, or adenylate cyclase in cyclic AMP. Phospholipase C. Okay? So just like the male, we have. Let me just write that quickly so at least we have a consistent, I know you know it already, but just so we have a consistent flow. So GnRH going to bind to anterior pituitary cells. Down to interstitial cells, except in the female. Anybody remember what our homologous structure, I just had it up on the board. What are the structures in the female that are homologous to interstitial cells? The ones on the outside, theca interna, okay? Now we haven't really described, other than last week briefly, these are going to go to theca interna cells. And theca interna cells are going to bind LH. And they're going to do so, they're going to be activated via CAMP. So adenylate cyclase and produce cyclic AMP. Okay? FSH is now going to bind to our follicular cells, the ones that are directly around the oocyte. And through the same process, it will bind to a membrane receptor, will activate G protein and adenylate cyclase. To form cyclic AMP. So remember our homologous sequence that I introduced U2 briefly in the female, although we were focusing on the male as shown in this slide. So then we have this diagram that shows the homologous structure of the skin. So here are the sustentacular or Sertoli cells. And remember, they are closely associated with the developing spermatocytes that migrate, enveloped by the plasma membrane, migrate to the lumen of the seminiferous tubule. And the interstitial cells are outside of that. In the female, the equivalent to the interstitial cells are the theca interna cells. And more closely associated with the egg, we don't have a lumen here, but we have the developing oocyte here, and most closely associated with that are the follicular cells. Okay? So LH binds to the interstitial cells and to the theca interna cells. FSH binds to the Sertoli cells and the follicular cells. So in the male, LH, and in the female, LH stimulates testosterone production. So if you recall this diagram, the interstitial cells in the male and the theca interna cells in the female are going to take cholesterol and convert it to androstenedione and testosterone. So I want to move this up a little higher so those of you in the back can see it. So can I erase what I have on the board? Well, I will, but let me know when you're ready. Okay. So here's the plasma membrane of a theca interna cell. It is binding LH on its receptor, which is activating the G protein adenylyl cyclase, and we get increased ATP to cyclic AMP. And then activated protein kinases. So what that does is activate the enzymes required by the cell. Cholesterol is going to enter the cell because it's soluble across the plasma membrane, right? Okay. And cholesterol is going to be converted to androstenediones. And to testosterone in the theca interna cell. What we see here. The androstenedione and the testosterone then are going to be transferred over to the follicular cells. And they were binding luteinizing hormone. Actually, sorry, that's luteinizing, follicular stimulating hormone. And again, ATP converted to cyclic AMP, activating protein kinases. And now the androstenediones and the testosterone are going to be converted to various forms of estrogens known as estradiols. So in the male, this side is emphasized. Primarily testosterone is produced, and the Sertoli cells produce just a little bit of estrogen. In the female, this side is emphasized. Certainly androstenedione and testosterone is produced, but most of it is converted to various forms of estrogens. Now both of these molecules are steroids. They're converted from cholesterol. And so they now can pass through the plasma membrane and affect the developing oocyte. So this whole process is equivalent in male and female. That's why I have those equivalencies between the cells. Now, when we talk about the follicular cycle and the ovarian cycle and ovulation, we have a spike in LH, and we see more of the theta interna cells actually structurally change. In addition to the progesterone, we're going to have cholesterol in the theta interna cells being converted to progesterone. So this activity right here will also take place after ovulation primarily.
And that takes place in the theca interna cells?
They change very dramatically after ovulation. You can't even recognize it anymore. They're large and round. All right. So now let's look a little bit at the changes that the egg goes through in oogenesis. We talked about spermatogenesis last week. So now let's look at the processes of oogenesis, and these are being controlled by the estrogens. Okay? So testosterone passed through the Sertoli cells and bound to the spermatocytes to regulate their changes. Estrogen is going to be doing the same thing to the oocyte to regulate its changes. So remember, these are my markers, if you will. So over here is a process of spermatogenesis. So the spermatogonium has undergone mitosis, tetrads and crossing overs occurring in the primary spermatocyte. And then the primary spermatocyte undergoes its first meiotic division to form secondary spermatocytes. So which of these would be the chromosomal pattern of a secondary spermatocyte? Which one? D. Okay, so it's our first haploid cell, meaning we have only, use chromosome 23, the X or the Y. But as you can see in the diagram here, we still have two copies. So we essentially have the sister chromatids. So we have two X's in this cell and two Y's in the other cell. All right? Okay, now let's look at this process for the egg. So when we do this in the male, we end up with our spermatid, and we undergo these cellular changes to end up with this elongated form of the sperm, delivering the DNA, whereas the egg is going to maintain its form. What we see is unequal distribution of the cytoplasm as we go through the cell divisions. Okay? So the same exact processes that are occurring with the chromosomes in spermatogenesis are occurring with the egg in oogenesis. The timing and the distribution is different. Right? So may I erase the board?
Yeah, I think I got it.
So in the female, the fetal female, oogonia are formed in the ovary and undergo mitosis, just like in the male. In the male, this mitosis stopped in fetal development and doesn't reoccur again until puberty is reached. In the female, it continues until primary oocytes are formed. So when a girl is born, she has no oogonia, all right? She has completed mitosis in fetal development, and in fact, many of the oogonia die off. It's only a couple 100,000 remain in the ovaries. But the same process, as far as cell division, occurs as the oogonia undergo mitosis. Daughter cells are formed, and they have the same identical chromosomal information, just as if a mitotic division would occur in any other body cell. Within the ovary, again, before the baby is born, the oogonia is going to form a primary oocyte. So when a baby girl is born, all of the eggs are in the primary oocyte stage. So the oogonium to primary spermatocyte, right, oocyte. Means that we have tetrads forming. So the sister chromatids of each pair of chromosomes stay attached to each other. Remember, that's what a tetrad is. So if this was an X from the mother, this girl's mother, okay, and a Y from this girl's father. Well, I'd be a blue color, sorry. And an X from this girl's father. So this girl is an XX. Now this replicated, and remember in mitosis we would have sister chromatids, and this would be the sister chromatid of the dad's chromosome, and they would line up for separation during anaphase. But in meiosis, the two sister chromatids attach to each other, and so instead we have this appearance. And so we would have one X from the mother and one X from the father of this girl. Okay, everybody with me? Exactly what I did for male, except we had an X and a Y. The mother and the father of the male. So this is a tetrad. Remember, during tetrad existence, we have crossing over. Random as to where and as to how much. Now I'm not going to keep redrawing that crossing over because it's pain. All right, but that's going to exist in this primary oocyte. Like the primary spermatocyte, notice there's no cell division between these two. It's just done the replication. So the oogonium is a 2N, the diploid cell. The primary oocyte is a 2N, but we have the tetrad, so we have two copies of each of those ends. So it's still a diploid. So all through the girl's childhood, toddler childhood, all the cells in her ovaries are primary oocytes. Then at puberty, under influence of the estrogens made in the follicular cells, the primary oocyte starts to go through the stages of metaphase and anaphase and telophase. Just before ovulation, we're talking less than an hour before ovulation, the first meiotic division occurs. Right? So if one egg is ovulated, only one egg is going to go that second meiotic division at that month's time. All the rest of the eggs that are unaffected by the estrogen levels will still be at primary oocytes. When this one was developing, about 12 to 15 other oocytes were also developing. Usually, however, they die off. They never ovulate. They would never complete the second stage of meiosis. Okay? So, just before ovulation, second meiotic division occurs. And we have an unbalanced distribution of cytoplasm. This structure is identified as the first polar body. And this structure is identified as the secondary oocyte. And this is what is ovulated. At that time, these split, and we have our first haploid cell. So, randomly, now I've made those chromosomes small. They're still the same size. They're not miniaturized. I just had to fit them into that little cell. So this is what is ovulated. And that's what you can see in this model here. So this is a protein coat that helps to allow only one egg to actually reach, and one sperm to actually reach the egg. And this is what's actually ovulated here. It's the egg, the yellow, with all the follicular cells around it. Okay? But we're streamlining the process and removing those. So this is the protein coat around it. Here is the secondary oocyte that's now going to be a haploid cell. And there is the first polar body, still captured within this protein coat. So even though I've drawn them separate, they're very closely associated with each other. And it has the same chromosomal pattern. And that chromosomal pattern is going to be just it, but 2 copies of it. Right? So this is a haploid cell. We don't have the X from the egg and the sperm. We have one or the other. But we have 2 copies. So again, N, but 2N. Just like our secondary spermatocyte. Now, if this secondary oocyte never comes in contact with a sperm, and none of the sperm that it may come in contact will actually penetrate their way through the protein coat, it's going to stay a secondary oocyte. It will never divide again. So in the cytoplasmic, intracytoplasmic sperm injection, it is that penetration of the needle into this protein coat and the plasma membrane that triggers that next secondary meiotic division. In normal activity, the sperm would penetrate through that protein coat and would attach to the plasma membrane, and that would trigger, sorry. I was thinking secondary oocyte. First meiotic division. And if fertilization occurs, this would divide again. Now we would have just a single copy of each of those sister chromatids. And we would have an ootid. But to be completely accurate, what do I have to add to that oocyte? I have to add the sperm's head. So sticking in through here is going to be the sperm with its DNA. So what we'll talk about on Thursday when we talk about fertilization is we often have the oocytes in our haploid chromosomal pattern, and here's the sperm. And then they gradually move towards each other as they start that first association of the chromosomal pairs between the mother and the father. Okay? So this is technically not yet a new zygote because the chromosomes haven't lined up. It's an oocyte with the sperm's nucleus in it. And up there would be the polar body. That first polar body may or may not divide again. Right? In this image, it showed it dividing again. It may not. This will divide to form a second polar body. And like the oocyte, it's going to have just one copy of the sister chromatids. So now the oocyte and the second polar body. So this first polar body is also haploid 2N. So both the secondary oocyte and the first polar body have the same chromosomal pattern, because they were both products of this cell division. Remember, the only thing that's different is the size of the cell. The second oocyte divides to form an oocyte and a second polar body. These are now just N. You can put the parentheses around it if you want. Same chromosomal pattern, because in the male, this would be the spermatid. All right? And so the chromosomes are the same pattern of division, even though the cells look very different.
So the larger cell will divide into two little ones?
So the secondary oocyte will divide into one little one and the oocyte. Okay?
So the first one divides into a little one
And a big one.
And then
So that's the first polar body. This may or may not divide to form two more.
Okay.
But this one definitely has to divide again because it's haploid but two parentheses in.
So
So this divides into another polar body and the oocyte or ovum is going to be, so it's not, yes.
Oocyte has two.
The
But we're
oocyte
calling it N.
is just in. And in humans, it would have 23. Because I started up here in this oogonium with 2 pairs of chromosomes. So remember, in our oogonium, we had this, X from the mother, X from the father, and then say chromosome whatever from the father, and it's comparable. So this cell was 2N, the oogonium. It's 2N. N in this case is 2. We have 2 different pairs. It's 2N because we have one from the mother, one from the father. If I made this a third chromosome, really got the colors here. Now this cell is 3N. Sorry, it's 2N, N equals 3. So it's in here equals 3, because we have 3 chromosomes that came from this little girl's mother, and 3 chromosomes that came from this little girl's father, when the sperm fertilized the egg. So all of this person, say this is me, and this is my oogonium, when I was a little baby. All the cells in my body that are 2N would look like this, where N equals 3. I only have 3 chromosomes. I would be a very different person. But I only have 3 pairs of chromosomes. But each pair, remember, is a pair because 3 chromosomes came from my mother and 3 chromosomes came from my father when the egg was fertilized. So the egg that turned into me had 3 chromosomes. The sperm that fertilized that egg that turned into me had 3 chromosomes. So now I have a set of 3 chromosomes paired. It was a little easier to understand in the sperm because remember one of those pairs, we had an X and a Y. So it was a little easier to identify it.
I guess I'm just getting confused because in the spermatogenesis, by the time we got to a spermatid, we were down to like only 1 in each cell. We had 4 cells that had
Right.
1 strand in each. And now
But
we have
remember, in
2.
actuality, each of those strands were really 23 different strands.
No, I get that. What's confusing me is we started with 1 tetrad, and here we have 2. Why do we have 2 and had 1 in the last one we did?
Just because the other tetrad is, I mean, there's 2 tetrads. So 1 tetrad, what we split was this, not the 2 things. So we split that tetrad into 2 sister chromatids. That's here. We split this tetrad into 2 sister chromatids. So one of each of these, so this part of the tetrad and this part of the tetrad ended up here.
Still not following.
Okay, let's
See,
Let's back up a bit. Let me turn off the slide and use this board.
it just looks like what you have in the ootid. It
In
looks
the
like what
sperm,
we
I
have in
only
the
followed the
spermatocyte.
X and the Y. I only followed one. So,
I get that you're following the X and the Y, but what's throwing me off is you use 1 tetrad, and I understood that to be all 23 chromosomes. I
Right.
understood that. But here you use 2 tetrads, so I'm like, why are there 2
It feels like
the
23?
reason I used 2 tetrads was more to, and I didn't kind of go that far with it, was to illustrate with metaphase. So let's go back. And some of you may not need to do this, so bear with me. In mitosis, let's see if I can use the same colors here. So in any given cell, and I'm going to go back to 3, just to not mix up the 2's, so you know which 2 is referring to what number, okay? So this cell, N is going to equal 3. Okay? Instead of 23 in the human. It always equals 23. When I did the male, I only showed the X and the Y. Okay? We just followed through with 1. But it's a little difficult to illustrate metaphase, which is 1 tetrad. All right? So we're going to look at 3, this organelle had 3 chromosomes, or in 3 pairs. So purple and black, I believe. So when N equals 3, then a haploid cell, 2N, is going to equal a total of 6. All right? So here we have 2N, where N equals 3. Now, let's say that each of the ones with a little squiggly on it, like that, came from the mother of this person, and the others came from the father of this person. Does that make sense?
Yeah.
Okay. Now, this would be any body cell, spermatogonium or oogonium. In mitosis, these form sister chromatids as the DNA is copied. So this is going to form a sister chromatid. And this is going to form a sister chromatid. Whoops, that's that one. This one forms a sister chromatid. And that forms a sister chromatid. That forms a sister chromatid. And that forms a sister chromatid. So we're in metaphase of mitosis. All right? In anaphase, these each separate and they're pulled apart. And so we have the maternal and the paternal form of each of those. And so we're back to our 2N. So this is going to separate over here and over here. This one comes over here and over here. Now I have 2 cells that are still 2N, where N equals 3. Okay? 3 chromosomes with their maternal and their paternal components. That kind of, okay, so that's mitosis. That's what your epithelial cells do, that's what your fibroblasts do, that's what your spermatogonia do if you're a male, and what your oogonium did when you were a fetus if you're a female. All right, so now let's move to the meiotic component. All right. So this is going to be an oogonium or a spermatogonium. And has undergone mitosis already. So can I erase this lower part of the board? Now we move into prophase. And so the next cell that I'm going to diagram is going to be a primary oocyte or a primary spermatocyte. The same thing is going to happen. So in prophase, we replicate each of the chromosomes. But unlike mitosis, the 2 sister chromatids of that pair stay fused together. So here's our replicated chromosome. And then from the father, that stays like that. So that's our tetrad. Okay? The other pair doesn't always have to be the mother on this side, so we'll switch it around. All right, so now they've lined up in metaphase, but as tetrads instead of as sister chromatids.
And will those have like little ends that, so have they already done the process where like a little green?
The overlapping? Yeah, I'm just not gonna, just assume that crossing over occurs, okay? That would get too complicated to
So
copy.
in the cell, that each one of those replicated, so they made its copy.
Right,
and
so
then
the
they
same thing has
attached
happened in mitosis,
Yeah.
like I drew earlier. Each of these is going to replicate, so that would be a sister chromatid of that chromosome, and sister chromatids of that chromosome, and sister chromatids of this one. But in mitosis, they don't remain attached. In meiosis, they do. That's what creates the tetrad, okay? So in metaphase of our first meiotic division, they're going to line up like this instead of just the sister chromatids, okay? All right, so these are now, they're still 2N because we have the sister chromatids, and they haven't separated, but because they're in tetrads, I write it like this. I mean, they've replicated. We have the same number of chromosomes in this first stage of meiosis as we did in mitosis. But the sister chromatids weren't associated. We didn't have the tetrad appearance. So I put the 2N in there to remind you that these are tetrads. 2 times 2 is 4, all right? So then we have our first, so this is a primary spermatocyte or a primary oocyte. And then we do our first, so let me try to take pictures. So that occurs. And then we have our first meiotic division as these separate. Now it takes almost an entire year in the female for this first meiotic division to go through all these different stages. All right? But finally, just before ovulation, we complete telophase and we complete cytokinesis, and we end up with the primary oocyte as two separate cells. Obviously, this occurs much more rapidly in the male. So for that to occur, and I'm not going to keep, well, I suppose I could. Let me move the name of this cell over here. So now we'll move this over here, and this is going to divide into two cells. And when it divides, this separates and this separates. Okay? So in this new cell, which is a secondary oocyte or a secondary spermatocyte, if it's a spermatocyte, we have the other cell large. If it's an oocyte, the other cell is small. So in this cell now, we're going to have and its pair will end up in here, still attached. Okay, just I can't fit it into that drawing. This chromosome will end up on that side, and this one over here, or in this little cell, but still attached, not to each other. And then this chromosome, replicated, will end up here. In the ovum. So in the male, these would both be secondary spermatocytes. In the female, this would be a secondary oocyte. And this would be the first polar body. Okay?
So do you have two cells, because the one you're trying to show is the oocyte and the other one's spermatocyte?
Right.
Here, okay.
So the two large ones would be, each of these would be a secondary spermatocyte. The one large one, one small one, this would be a secondary oocyte, and this would be the first polar body.
So the egg only won't get it won't get any of the genes that came from the first polar body.
The same division occurs. We end up with one set of N chromosomes. Right. Those are, I mean, we only use one sperm anyway, so it's not like the others aren't wasted. But we don't see as many eggs develop from one oogonia as we do from one spermatogonia.
But do they have the same exact, does the first polar body and the...
They're not going to have the same exact chromosomes
genetic.
because remember,
Okay.
there's crossing over that
Yeah.
occurs. Plus, this is the chromosome that came from your mother. This is the chromosome that came from your father. So obviously, they're not going to be the same. And when there's crossing over, so they're more likely to be a little bit, they've shared some stuff, but they're still not exactly the same. They're still chromosome 20 or chromosome 10, but they're not exactly the same. One might have dominant genes and the other recessive genes for the same traits or enzymes. Okay, enough of it's the same that you still are a human being,
Yeah.
but different hair and color and other things that are created by that. All right, so now we've gone from a 2 parentheses 2N. So now our secondary oocyte is 2 parentheses N. Our secondary spermatocyte, both of these would be the secondary spermatocyte, is still 2 parentheses 2N. And our first polar body is 2 parentheses 2N. Because we have 2 copies of each of the components of the chromosomal pairs.
So is that all X's in that one or something? thought we
No,
were
only,
talking
this,
about.
this would be the X from the mother's egg, and this would be the X from the father's sperm. These are different other chromosomes. So this would be chromosome, that's chromosome 23 in the human. We have 23 of these in the human. So it could be chromosome 2 or chromosome 5 or chromosome 8. They all have different genes on them, okay? So only in the female, we have 2 X's, one from the mother and one from your father. In the guy, the sperm has an X and a Y. Okay, so that was easier to name them that way. Now, we're not done yet. We're at this stage right here. Okay, so we need one more meiotic division. In a male, that would just go ahead and happen, because remember the secondary spermatocytes divide in their second meiotic division very quickly. In the female, this secondary oocyte has to wait to get fertilized for the stimulus from the fusion of the sperm to the egg membrane. When that happens, this will divide again. That may not. So if this is our secondary spermatocyte here, all right? And this would form similarly sized cells, but in the, so that would be the male, all right? In the female, this one is instead going to be another small little cell. And so this will split, and one will go in here, and one will go in here. If this is a male, the other one will go in here. Okay. And then for this one, because this is a male, we don't, in our female, it's the first polar body, so we're not going to worry about it. But in the male, it's our other secondary spermatocyte. So we split those sister chromatids. Same with the other chromosomes. The secondary spermatocytes, the egg would have this, and the little polar body would have the other one. The secondary spermatocyte would do that. Again, these are both spermatocytes. And then here our egg. Okay? So this would be then our oocyte, if we're female. Second polar body, if we're female. And if we're male, this would be a spermatid.
So the female only really creates one,
Correct.
and the male will create 4.
One functional one?
Yeah.
Yes.
And then the male creates 4 functional.
Right.
And they're all X.
Mhm. So, in the female, this would be the oocyte, and it would be in. And the second polar body would also be in. So you may just have to sit down with this image or with colored pens and kind of do the same thing on your own to follow it through. Again, the same thing occurs in the male as occurs in the female, just a different cytoplasm volume. page 112, and there'll be time to let you go and put your brains rest in.
Okay.
Something I didn't call in sick today. All right, so this is a diagram of the ovary. And on page 12, both the top and the bottom are showing the various stages that the follicle goes through. So we've been using these terms, talking about the homologous structures between male and female. So they should not be unfamiliar to you, but we can see them a little bit more in relationship to these components. So this is the ovary. And remember, the oocyte is surrounded by the follicular cells. And so these are always, each of these eggs is always going to be a primary oocyte. Okay? All of the oocytes that we find in the cortex are primary oocytes. The only one that is not is the one here that's being ovulated. Okay? So sometime between here and here, it completed that first meiotic division. This would be a secondary oocyte with a little polar body associated with it. Now, I use a slightly different set of terms than your textbook does based on the histology course, the textbook I use for that. So your textbook starts out with the primordial follicle. I'm not going to use that term. Okay? Now, word of caution, remember the oocyte and the follicle are two different things. So the oocyte is the germ cell. It's the egg, if you will. And as I indicated, it's always a primary oocyte if it's within the ovarian cortex, and it's a secondary when we see it at ovulation. The follicle involves these cells, the brown cells. These are the follicular cells that we talked about finding FSH. Then we see the little black dots, and those cells are the theca interna cells. As the follicle starts to grow, the follicular cells are often referred to as granulosa cells when they're actively synthesizing estrogen. I kind of go back and forth between them, okay? So follicular or granulosa are going to be independent. So when we look at cells that are not under the influence of FSH and LH, we have our primary oocyte with the nucleus, or rather, no, nucleus and nucleus. So this is a primary oocyte. And it's going to be surrounded by flat squamous epithelial cells. Remember, squamous cells don't have the organelles that they need for protein synthesis. In this case, they're synthesizing steroids, so there would be very little smooth ER present in the cell. And so we would just have flat cells around. There are theca interna cells there, but in the microscope, they're impossible to see. Okay? So this whole structure is identified as a primary follicle. Again, your textbook would call it a primordial. So then as LH levels start to rise, okay, and FSH levels are rising at the same time, they're going to start affecting the appearance of these cells. And follicular stimulating hormone binds to these follicular cells. And some of them are respond, some of them show more receptors than others. So about 12 to 15 of our primary follicles will respond to these rising levels, particularly of FSH. And so the next step is we see still the primary oocyte, but now the follicular cells, as they start to increase their smoothie R, become cuboidal. As soon as the squamous cells become cuboidal, still a primary oocyte, but now this is identified as a secondary follicle. It's still a secondary follicle and a primary oocyte when the follicular cells multiply again, still under FSH stimuli. So multiple layers of follicular cells is still identified as a secondary follicle.
Still primary oocyte.
Still a primary oocyte. And now we start to see those theca interna cells. And with more evolved theca interna cells, we'll start to see estrogen now being synthesized by the follicular cells. So let's stop there. And then on Thursday, I'll come back and then we'll pick up the ovarian cycle as we go through here to ovulation and compare that to what's happening to our LH, FSH, estrogen, and progesterone levels. And then we'll also talk about fertilization on Thursday. So Thursday you have your second lab quiz, and that will be all male. So it'll include male reproductive models and at least a couple of male histology slides. So either 3 and 3 or 2 and 4. 2 to 3 histology